assess the nutritional support, ways of the nutrition support, how we can give enteral or parental nutrition, and the take home message. What is clinical nutrition? It is the science that interprets the nutrients and other substances in food in relation to maintenance of growth, reproduction, health, and disease of an organism. The nutrients are organic and inorganic complexes contained in the food. They are broadly divided into macronutrients, which are proteins, fats, and carbohydrates, and the second one are the micronutrients, which are vitamins and the minerals, which are essential for the body. The aim of nutrition support is to identify patients at risk for malnutrition and to meet their nutritional requirement. In surgery, malnutrition is common. It occurs in about 30% of surgical patients with GIT disease, and in about or more than 60% of those in which hospital stay has been prolonged because of post-operative complications. So the malnutrition has a high risk of morbidity and mortality. When we start the nutrition support, we have to check the patients by seeing that the patient can safely swallow or unsafe swallow. If the patient swallows safely, so the nutritional support should be given orally, and if the patient is unable to swallow, so if the GIT is intact or GIT is normal, so we have to give priority to the enteral feeding. But if the patient is unable to take through the GIT, so we have to give the parenteral feeding. Physiologically, after a short fast lasting 12 hours or less, most food from the last meal will have been absorbed. Plasma insulin levels falls and glucagon level rise, which facilitates the conversion of liver glycogen to glucose. This occurs in 12 hours, but when the fast is longer, so the glycogen is from the liver is converted to glucose. But if the fast is more prolonged, after 24 hours, the protein which is stored in the muscle tissue, which is start breakdown by the help of the enzymes, and the amino acids are taken to the liver, and where the gluconeogenesis starts, and after 48 hours the lipolysis starts in the muscle, and the glycerol, which is the basic unit of the fat or the lipid, which is then shifted to the or transferred to the liver, where gluconeogenesis starts. And there are several organs which use glucose as the basic and the obligatory or the essential food. These are the brain, RBCs, WBCs, and the renal medulla. So for that the glucose is necessary. In trauma or in sepsis, when there are several hormones come into action, and the counter-regulatory hormones, these are the epinephrine, and the thyroid function hormones, they come into play and regulate, and in which the glucagon and the insulin, these are the five hormones which come into action, and there is insulin resistance, and these all preserve the function of all these is to preserve the glucose and utilize the protein and the lipids from the storage sites, and they retain the fluids. An average adult needs 30 to 35 kilocalories per kg per day, which approximately in 24 hours comes to be 1300 to 1800 kilocalories. The 1 gram of carbohydrate provides about 3.4 or 4 kilocalories, and protein also provide 4 kilocalories, but the fat, 1 gram of the fat provides 9 kilocalories. These are some causes of the diseases which can cause the malnutrition. Reduced food intake, which is the patient is anorexic, or the patient is in fasting, or there is a swallowing difficulty, or the pain, or the mental or physical impairment, or the gut is not functioning properly, is so, and the altered metabolism like trauma, burns, sepsis, or surgery, or if there is the cancer. So these are the common causes of malnutrition. And after that we assess the nutritional status of the patient by taking the history and dietary history and history of the weight loss. If the patient is not taking food for prolonged time, and if there is a history of weight loss more than 10% for within 3 to 6 months, it means it is the severe major weight loss, and the patient needs nutritional support. After that, after taking the history, we start the clinical examination. On general physical examination, the malnourished patient will be emaciated, apathetic look, and body fat stores like the skin fold examination over the biceps and the triceps, and assessment of the protein stores like the muscle bellies of the biceps, tricep, and the metabolic assessment of the metabolic stress, indirect calorimetry, temperature. The patient will be cold and clammy, and the WBC count will be decreased. Pulse will be rapid or decrease. If there is a septic patient, if there is a pulse or abscess in the peritoneal cavity or in the body planes, so these are the parameters which we assess by doing the ultrasound, and on physiological function there will be poor wound healing, early fatigability, and the grip strength will be less, and the respiratory muscle function test will be positive. The body weight and anthropometry are the main assessment points, and the laboratory tests are the serum albumin level, lymphocyte count, and skin hypersensitivity test. There is a malnutrition universal screening tool which comprises having 5 steps, in which one is the BMI, calculation of the BMI. BMI is the body weight, and the height by measuring these two. The body weight is divided by the height in the meters, and the weight loss in 3 to 6 months, and if there is a acute disease. These comprises 6 points, and by adding these points, if it is 0, it means a patient not needs any it means there is no nutritional, the patient needs low nutritional support. But if the score is 2 or less than 2, means the patient needs observation. But if the score is 2 or more than 2, the patient needs treatment. This is the BMI. The normal BMI is 18.5 to 25, but underweight is 16, and severely underweight or the malnourished is the 15 or less than 15. Above 25 is up to 30 is overweight, and 30 to 35 is obese, class 1 and class 2 and class 3. So the nutritional indication are when there is a past medical history, when there is involuntary loss, weight loss is more than 10% of the body, and body mass index is less than 18.5, and serum albumin level and the transferrin level are less, and failure to thrive if there is a severe burn, trauma, sepsis and pancreatitis, and if the patient NPO is more than 7 days. These are the indication for nutritional support. We can give nutritional support through enteral or the parental routes. This diagram showing the enteral and the parental routes. The nasogastric tube and the gastrostomy tube, jejunostomy tube, nasojejunal tube, and the TPN and the peripheral nutrition. The enteral nutrition means we supply through oral cavity, or we are using the gastrointestinal tract, which may be oral supplements or through the NG tube. If the patient is not taking or is unable to swallow, so we can give, or we have to start through the NG tube. And there are two types of NG tube, fine bore and the wide bore. If the nutritional support is needed for less than 2 weeks, we can give the NG feeding. But if the nutritional support is prolonged more than 2 weeks, we have to give through the gastrostomy tube or through the jejunostomy tube. The gastrostomy tube can be formed through surgically or through the PEG, which means the percutaneous endogastric tube. And the jejunostomy tubing, which can be formed laparoscopically or by the open surgery. Oral feeding are the sip feeds, which are commercially available in the 200 kilocalories in a carton. These are commercially available in the market, which provide 200 kilocalories. Given in those patients whose appetite is impaired, oral diet started at regular intervals more frequently, and progressive shift from oral liquid to soft and normal diet ideally be one between 2 to 3 days. Tube feeding is the NG tube or fine bore tube. So the 20 to 30 ml are administered per hour initially, but gradually we have to increase, and overnight we have to discontinue because of the risk of aspiration. And aspiration is performed on regular basis. If aspirate is more than 200 ml per 2 hours, stop feeding temporarily, because if we give the more fluids or the more feeding through the NG tube, it causes aspiration and the complication aspiration pneumonias. The fine bore tube, it is made of silicone, elastomer or polyurethane, but these tubes causes few gastric or esophageal erosions. The gastrostomy are two types. One is temporary and the other one is permanent. Temporary is used for more than, if there is a need of more than 2 weeks nutritional support, so we can form the gastrostomy through the stem method. Or the permanent technique is the Janeway, in which we make the stomach as a tube, in which the some part of the muscle of the wall of the stomach is used as and the form as a tube, which is then connected to the skin, and the tube is passed through this tubing of the stomach, which is permanent. If this is the second technique, this is the gastrostomy tube, which is formed by the percutaneous endoscopic method, which is done in local method, and there is no need of GA. If the endoscopic facility is available, now it is preferable that the PEG should be performed. The other method is jejunostomy tube, which is in which the tube is placed in the jejunum, which is 25 or 30 centimeter from the DJ junction, and it is safe. Now it is, if we are doing laparotomy, so the patient needs the tubing or the gastrostomy or the jejunostomy tube, so the preferably we put the jejunostomy tube. There is a less risk of aspiration and less complications. So the complications of the enteral feeding are the tube may be malpositioned or displaced, blockage or leakage, and the tube may break, and erosion of the skin and the mucosa. There may be gastrointestinal complications like diarrhea, bloating, nausea, vomiting, abdominal cramps, and aspiration, and the constipation. These are some complications. And the metabolically, the electrolyte disorder, vitamins, minerals, trace element deficiency, and aspiration overloading. So the feeding should be done in the recumbent position, and there may be solute overloading, diarrhea, which leads to diarrhea, dehydration, electrolyte imbalances, and rarely the tube can perforate the gut, stomach, or the jejunum. But there are some advantages of the enteral feeds, because it preserves the gut integrity, decrease likelihood of bacterial translocation, preserves immunological function of the gut, increase compliance with the intake. The cost is less as with the parenteral nutrition, and the intake is easily and accurately monitored. These are some contraindications. When there is intractable vomiting or diarrhea, and there is paralytic ileus or the intestinal obstruction, diffuse peritonitis, severe GI hemorrhage and gastrointestinal malabsorption, and short bowel syndrome, and severe shock, distal high output fistulas. These are some contraindications, and these are the if the patient need nutritional support, these are the indications for the parenteral nutrition. So this chart suggests the monitoring schedule for the enteral feeding, the electrolytes, complete blood count, glucose level, urea and creatinine, nitrogen balance, and intake output, body weight, urine output, and stool. These are monitored in the acute patient. These are monitored daily basis, but if the patient is stable, we monitor on the alternate 2 or 3 times a week in stable patients. The parenteral nutrition is defined as infusion of a nutrient which is hyperosmolar solution containing carbohydrates, proteins, fat, and other essential nutrients through IV route, which are delivered via indwelling intravenous catheter. The components are in elemental or pre-digested form. So there are techniques. One is the peripheral parenteral nutrition, and the second one is the central parenteral nutrition. We can give peripheral through the peripheral line if the nutrition support is needed for less than 2 weeks, and if we are using the peripheral line, so we have to give 5 to 10% of the dextrose, and amino acid concentration should be less, and the concentrated lipids should be not more than 20%, because they can cause the thrombophlebitis, and osmolarity should be less than 900 milliosmoles per liter, which are delivered through into the peripheral vein. And the total peripheral parenteral nutrition, by which we can give 50% or up to 70% of the dextrose, amino acids are 8.5 and 10%, and the osmolarity can be increased. We can give hyperosmolar fluids by the central venous catheter. These are the sites. If the need short-term central access, so the infraclavicular approach to subclavian vein is better, but if the long-term central access is needed, then tunneled catheter into the subclavian or internal jugular vein are favorable, because these having less complications. And if the nutritional support is less than 1 week, so the PICC line or the percutaneous inserted central catheter is used. We can use by the PICC line, but having complication, if we use more than a week, then thrombophlebitis is lethal complication. The picture showing the lines, central or subclavian and the clavicle, subclavian, and the superior, which the tube is in the just above the superior vena cava. Advantages of the central or the which we can provide nutrients when less than 2 to 3 feet of small intestine remains, allows nutrition support when GI intolerance prevent oral or enteral support. This is the Harris-Benedict equation by which we can estimate energy requirements, but there is some difference in men and women. So we have to weigh the patient and height of the patient and age of the patient. By calculation these we can calculate the energy which is required. If the patient is bedridden, we have to add the activity factor. If the bedridden patient 1.2 activity factor and the patient is mobile, so the activity factor is 1.3, and disease factor is the general surgery 1.2, sepsis 1.3. so if the multi-organ failure, so 1.6, and burn patient, so 70 to 90%, the burn in the 1.8% we had to add. There are solution available. There may be separate solutions like the dextrose, protein and the fat, but they are commercially available 3-in-1 solution. So we had to calculate that the sugar or the glucose is provided in 60 or 70%, and the lipid is provided in 20%, and the protein is provided in 10%. So this is the slide which is showing that how much we are giving. We have to give the 10% amino acid, 70% of the dextrose and 20% of the lipids. We calculate 1800 kilocalories per day. These are the complications of the tubing which are past the CVP line through the PIC line or through the central line. So this may be malpositioned, or it can cause hemothorax, pneumothorax, ear embolism, blood loss, puncture of the subclavian artery, and metabolic complications like fluid overload, hyperglycemia, hypophosphatemia, hypokalemia, hypomagnesemia, refeeding syndrome. So the refeeding syndrome is the syndrome in which the patient is severely malnourished and patient is not taking for so many days. So if we start the feeding, to the patient develop hypophosphatemia, hyperglycemia and fluid retention and cardiac arrest. So cardiac arrest the ECG changes will be developed in these, and hypotension, arrhythmias, cardiac arrest, weakness and paralysis, and the respiratory depression. So we have to prevent first, but if the patient has developed refeeding syndrome, we have to give treatment. So before starting the feeding, we have to correct the electrolytes abnormalities, and we have to continue monitor serum electrolytes and initiate nutrition support at low rate concentration, and then slowly and gradually we have to increase the nutrition concentration. Overfeeding usually results from overestimation of the caloric needs, and overfeeding can lead to hyperglycemia, hepatic dysfunction from fatty infiltration, and respiratory acidosis from increased carbon dioxide production, and difficulty weaning from the ventilator. For the monitoring, there is no single criteria. So for the checking of the CVP line, we had to do the chest X-ray for the placement of the CVP, and clinical monitoring 4 hourly and daily weight of the patient, and site care from where we have placed the CVP line. We had to care on daily dressing changes, and we had to monitor the IO charting, intake output charting. The RBC monitoring 3 times a day, and daily electrolytes, calcium and magnesium, are done twice weekly. LFT and creatinine, albumin, and hemoglobin and INR are weekly basis. Urine checked for regularly for glycosuria. The short bowel syndrome is common in surgical patient. When we resect the gut, more than 70% of the gut is resected for the gangrene. So these patients are more prone for the development of the short bowel syndrome. If remaining bowel is disease already, or with impaired absorption, or decreased intestinal surface area, decrease in intestinal transit time, decrease in intestinal absorption, and gastric acid hypersecretion, and which leads to gallbladder stones, and absorption of the xanthine leads to nephrolithiasis. The treatment is adequate replacement by IV fluids, electrolytes with zinc, and HO receptor antagonists like the omeprazole, and bowel adaptation period until feeding started as soon as possible once stool output is less than 1000 ml per day, and glutamine and medium chain triglycerides to maintain the mucosal healing. Long-term treatment, small and frequent oral feeds started in intake colon. Diet rich in complex carbohydrate are given. If terminal ileum has been resected, vitamin B12 is given monthly basis, and vitamin B12 and the when the patient having gastrointestinal fistula, we can define that the diversion of the intestinal contents commonly to the skin, and the common causes are Crohn's disease, bowel surgery, radiation injury. So the gastrointestinal fistulas are divided into high output fistulas and the low output fistulas. When the output is more than 500 ml, so it is called the high output fistulas. So the take home message is malnutrition leads to prolonged stay, prolonged recovery time period, and the increased medical cost, increase caloric requirement is 30 to 35 kilocalories. Use enteral feeding unless